Start, Maina. So, good morning, one and all. So, I welcome to you all of you to our instruction course, What Next? So, posterior segment disorders have always been an enigma to most of our ophthalmologists. So, whenever we see a case, we are always wondering whether we have to observe it or should we treat it, and if we are planning to treat, how to investigate whether it requires surgical intervention or can be managed medically. So in this instruction course, we'll look at the posterior segment disorders which we usually come across, such as an ERM, CSR, diabetic macular edema, age-related macular degeneration, and posterior segment uveitis, which we come across very often, and we always ponder whether should we treat it, should we refer it to a VR surgeon. So I'm Dr. Rahul. I'll be talking to you about an algorithm for the management of a case of central serous retinopathy. So, whenever we look at a case of CSR, it could either be an acute CSR, a chronic CSR, a atypical CSR, or a variant of CSR called as PPCS, that is peripapillary pachychoroid syndrome. So, an acute CSR will usually have a history of around 3 to 6 months. You will see macular fluid on fundus examination. On OCT, you will see a pachychoroid, that is a thickened choroid, subretinal fluid, and serous pigment epithelial detachment, that is PEDs. And autofluorescence usually will be insignificant. Chronic CSRs will have a history of more than 6 months. On examination, along with macular fluid, you'll also see pigmentary changes. On OCT, you will see the pachychoroid, subretinal fluid, and serous PEDs, and FIPED, that is flat irregular PEDs. So if you see over here, this is the normal PEDs that we come across in CSR. This is dome-shaped PEDs. Whereas the FIPED is a sign of chronicity. So you will see such flat irregular PEDs, which could be either vascular or avascular. And in autofluorescence, you can see abnormal autofluorescence with patches and tracts. Atypical CSR will have a bullous SRF on OCT. So usually in CSR, we are used to seeing only subretinal fluid. Whereas in atypical CSR, along with subretinal fluid, you'll also see intraretinal fluid, and along with that you can see FIPEDs over there. And the next entity is peripapillary pachychoroid syndrome. So whenever you see these cases, you will see small disc and nasal pachyvessels. So what happens is, usually when we talk about pachychoroid, if you look at the choroid here, this is a PPCS. So normally the temporal choroid will be more thicker than the nasal choroid. In PPCS, you will see that the nasal part of the choroid is much more thickened, and along with subretinal fluid, you will also see nasal schisis, that is the fluid in the intraretinal region. So, this is the algorithm for a case of CSR. I know it looks very complicated. I'll just try to break it down. So, acute CSR, any first episode of CSR, we will usually observe, okay? And we can start them on topical NSAID drops or topical carbonic anhydrase inhibitors, and ask the patient to avoid stress, because most of these patients are type A personalities. And we also, if the patient is on some topical steroids, we try to look into the steroids, and unless it is absolutely essential, we can actually ask them to take them off steroids. Now, acute CSR, like we said, most of us will usually observe, but when do we treat it? So, if the fluid is not resolving over a period of 3 to 6 months, if there's a progressive vision drop, or you see abnormal SHREM on OCT. SHREM is subretinal hyperreflective material on OCT. So this is an OCT finding. So in this OCT, if you see, you usually see the serous fluid will be completely dark colored in OCT. It's completely clear. Whereas over here, you can see, along with this, in the subretinal fluid over in this temporal nasal region, you can see some white spots over here. So this is SHREM. Now, technically speaking, SHREM could be either blood or any hyperreflective materials, but usually in case of CSR, it is fibrin. Now, you see a case of CSR. What next? So, subject this patient, after the OCT, subject the patient to FFA ICG. Now, in FFA, you can either get an ink blot leak, like over here, or you can get a smokestack leak. Sometimes you might also get multiple leaks. On ICGA, you will see choroidal hyperpermeability. So once you get the leak, determine whether the leak is extrafoveal or foveal. If it's extrafoveal, the treatment is straightforward, focal laser to the leak. And if it's foveal, then you can think of reduced fluence PDT, you can do a micropulse laser, or you can start the patient on eplerenone about 25 to 50 milligrams per day. Now, that was about acute CSR. In chronic CSR or a typical CSR, again, get an FFA and ICG. In FFA, you will see focal leaks and staining. Sometimes you will just see diffuse staining. You won't find a pinpoint leak. On ICJ, you will have, along with choroidal hyperpermeability, you will see focal hypersynescence. I always prefer to advise OCT in such cases because this is one case, one condition where the OCT has an edge over FF and traditional dye-based angiography. So once you get the OCTA, you're basically trying to ascertain whether the patient has a CNVM. So on OCTA, if you see a network, take it as a CNVM and treat it with anti-VEGF therapy. If you don't find a network and you're just seeing staining or leak, if the leak is extrafoveal, do a focal laser. If it is foveal, again the treatment is PDT, micropulse laser, or you can start them on eplerenone. Now, not all that glitters is gold. Okay, so be wary of a condition that is VKH. So both of them come almost in the same age group, VKH as well as CSR, because we see it in second to fifth decade. Okay, and if you see a case of CSR, now let's try to, you will always see, depending on what stage of VKH you are seeing, sometimes you might see in the prodromal stage you won't find much inflammation, but usually VKH will have some amount of inflammation, whereas CSR will usually be non-inflammatory. Now, if you look at the OCT, we'll go from bottom to up. So you look at the RP over here. So the RP in CSR will be completely straight, except for the small PD, clear PDs here. Otherwise, the rest of the RP will usually be very clear, unless it is a chronic CSS, where you might see RP disturbance, but still the shape of the RP is well maintained. Whereas in VKH, if you see, it will be a lumpy, bumpy RP. You will see multiple folds of RP. And in CSR, you will see subretinal fluid, which you can also see in VKH. Along with that, in a case of chronic CSRs, you can find intraretinal fluid or schisis in CSR. Whereas in VKH, there's a condition called as Ballard, that is basilar layer detachment. So what happens is, this intraretinal fluid is usually, basilar layer is, what happens is, the fluid is collected just above the photoreceptor layer. So if you see over here, this is the photoreceptor layer over here, and the fluid is collected just above it. And along with that, the vitreoretinal interface, that is the ILM, everything will be very clear in CSR. Usually it will never be affected. Whereas in VKH, you will see multiple fluctuations of ILM. Now, what happens is, most of the time we see a case of macular fluids, SRF, like projecting right on our face, we tend to ignore the optic disc findings. Always and always make sure that you see a macular fluid, always look at the optic disc, because there might be a subtle optic disc pit. Because the management in optic disc pit is, even though we advise laser and everything, the best treatment that we have felt like best for optic disc pit is vitrectomy. Thank you. So I think we'll keep the discussion at the end of it, and I invite Dr. Chirenshin Matthew for the next talk. He will be talking about the algorithm in a case of vitreomacular interface disorders. He is a medical superintendent at Chaitanya Eye Hospital, Tiruvalla. He is an excellent VR surgeon as well as a cataract surgeon, which is a very rarity in the entire Kerala. So I welcome Dr. Shane.
So good morning to all. I think there's a slight delay. Just an introduction on what I'm going to speak. I'm going to talk about vitreoretinal interface abnormalities. The word looks very large and huge and misleading, but it's nothing but problems between the vitreous and the retina, surface of the retina. This is a problem which we never used to really look into, because probably we did not have good investigative modalities to find them out. But with the advent of high definition OCTs, we are now able to pick up these subtle disorders, yet symptomatically or visually very challenging. And the good thing is there is effective treatment. I mean really effective treatment for it, and probably it is one of the areas where vitreoretinal surgeons like us are delighted to see the results. So we'll have some more time on it now. Yeah, that's also surface, but that's a different surface. So we'll go to the proper surface which I am going to deal with. Just come here, I don't know. So a patient with vitreoretinal interface abnormalities, how do he present to us or she present to us? So the patient may have a subtle change. You look at the anterior segment, it's okay. You look at the fundus, more or less okay. But they say that, doctor, I definitely have a blurry vision, and it's of recent onset. Or the patient may complain of metamorphopsia. Rarely, even photopsia can be a symptom of vitreomacular interface abnormalities. The moment you see flashes, we think of a peripheral retinal break causing this, but even a vitreomacular interface abnormality can produce photopsia. Okay, so I think I'm good to go. So in the next few minutes, we'll be talking mostly about vitreomacular adhesions, vitreomacular tractions, macular holes, especially lamellar and full thickness macular hole, not forgetting epiretinal membranes. It is found in 1.5% of the population. So the magnitude of the problem is larger than what we think. And one of the important diagnostic tools is a simple Amsler's grid. This is going to tell you whether the patient has metamorphopsia or not. Multicolor imaging, it has come up in a big way in diagnosing vitreoretinal interface abnormalities, especially epiretinal membranes. In the presence of cataract, this will give you excellent images so that we can now know the margins of the membranes on what is happening beneath the retina, what is the status of the RP in the presence of an epiretinal membrane. So multicolor imaging is yet another good tool in assessing vitreoretinal interface abnormalities. By far, the most accurate method of diagnosing this condition is by doing an OCT, and it helps in following up, monitoring post-surgery and prognostication of these diseases. There are umpteen number of morphological alterations seen on OCT as described in the literature. Some of them are very valid, some of them is not so valid as well. Treatment, vitrectomy is the treatment of choice with 85 to 98% anatomical and functional success reported in the literature. Other treatment options include pneumatic vitreolysis and ochraplasmin. In the recent past, there has been a decline in the use of ochraplasmin, especially abroad. In India, we have not got it so far, but there was a decline. That's because of the toxicity of the drug as well as the suboptimal response following the treatment. So by and large, vitrectomy is the treatment for these disorders. So this is an OCT of a vitreomacular anomaly. So how do we make a diagnosis? So we have a vitreous attached to the fovea, but the anatomy and the integrity of the fovea is maintained. This is what is called a vitreomacular anomaly. So this patient, asymptomatic though, we saw something slightly whitish here, took an OCT, and this is what we saw. So this is an asymptomatic patient with a vitreomacular traction. So we name it vitreomacular traction because there is an anterior retinal change. So you see a traction with a retinal change, you call it a vitreomacular traction. And this is called a pseudo hole. The patient is asymptomatic, so we just keep observing. We give them a home Amsler's grid, patient goes home, check for any changes, and if there is worsening of symptoms, we definitely consider treatment. So here is a patient with Yeah, yeah. So here is a patient with vitreomacular traction, and the patient is mildly symptomatic. Even in mildly symptomatic cases, here we have only anterior retinal changes. You tend to observe, but observe very closely. If the patient's VMT increases or a posterior segment changes happens, you need to treat it immediately. But sure and certain, within a 1 month's time, there was a spontaneous release of this VMT. So there is a chance that 30% of the cases may have a spontaneous release. But there is also a chance that 70% of the patient, if the VMT does not release, will have visual deficiency. So that is what I'm going to highlight in the next of my talk, in the few minutes of my talk. Epiretinal membranes, they are fibrous proliferations on the surface of the retina or to the posterior hyaloid phase. This is a slide to show you the importance of operating an epiretinal membrane early. On the left hand side, we have an early epiretinal membrane with good visual acuity, but the patient was mildly symptomatic, mild metamorphopsia. We did surgery, the patient got back 6/6 vision with a good anatomical contour of the fovea. Here is another case where we waited for the vision to drop to 6/60. This was the older concept. We were taught that the visual acuity has to reduce beyond 618 or 624 to consider surgery. See what has happened. We have done a good surgery, removed the epiretinal membrane, but the BCVA is only 6/18. There was an improvement though, but it has not come back to 6/6 or 6/9. That is because of the irreversible damage of the inner retinal layers seen on OCT. So the message or the take home is operate epiretinal membranes early and don't wait for it to drop down if the patient is symptomatic. So when do we not consider surgery or when do we delay surgery? There are a few instances when we have vitreomacular anomaly with advanced glaucoma. Already the RNFL is damaged, the retina is thin. Any trauma to that may exemplate or exemplify the visual loss. So this is a patient where we are not very keen on operating these patients. At another area is where there is a lot of RP damage at the macular area. The visually may not benefit. So these situations we may hold on for surgery. Especially a macular hole with mactal or a foveal atrophy. These are situations, or a patient with macular hole and macular ischemia, we do not operate because we know that the functionality will be very less following surgery. But in rest all cases, surgery is the treatment of choice. There are certain not so good or bad prognostic signs following vitreomacular interface abnormalities, like patient has a vitreopapillary traction, a cystoid macular edema, tractional detachment, a macular schisis or a broad-based vitreomacular traction, an epiretinal membrane along with the broad-based traction are all negative correlates to good visual acuity. Govito et al. Classified epiretinal membrane into 4 stages. So the fourth stage, you can see there is a complete disorganization of the inner retinal layers, whereas in the second and the third stage you don't have. So try to operate the patient when they belong to the second and third stage and don't delay it to the fourth stage because you may have irreparable damage. Better prognostic biomarkers in OCTs are a good shorter duration of symptoms, a V-shaped or a focal VMT, a thinner preoperative central macular thickness, and a post-operative restoration of the inner and outer retinal layers. So coming to the macular hole, we all know, initially the first group who published results of macular hole showed a success rate of 30%. 3 years later, the same group published with the success rate of macular hole as 70%. Now years down the lane, we boast about a success rate for 95 to 96% of most of the cases, at least anatomically. So just take one more minute, please, Rahul. So this is a case of a relatively large macular hole which underwent vitrectomy. It's around 1000 micron size hole. There was a good anatomical reconstruction. We did an internal limiting membrane peeling and a bridging flap. You can see that the internal limiting membrane flap bridging the hole. So now the concept about macular hole surgery, we do internal limiting membrane peeling in almost all cases, and larger macular holes we bridge the gap of the hole with internal limiting membrane to facilitate closure and better anatomical integrity. So the current practice is that, and here is yet another patient. She came to me with the complaints of defective near vision since 1 week. This is to exemplify what I discussed at the beginning of the talk. The right eye showed a macular hole, everybody knows, and the left eye shows a vitreomacular traction. So the point is, which eye do we operate first? I operated the left eye. The vision is good, but my point is, this is what the patient came from. She had a recent drop in vision in near vision. It is not because of this big a macular hole. She would have had less vision in this eye since a long time. So I operated the left eye. This is 2 years down OCT, 6/6 vision with a normal foveal contour. Operate these eyes, especially the ones with other eye macular holes. Even in early VMT, you need to consider surgery because definitely that's going to give good visual acuity. The other eye also we operated, had a type 1 closure of the macular hole, but the vision is only 6/36. So that is my take home message. A lot of OCT biomarkers like the minimum linear distance, the basal linear distance, and also the whole edge height configuration, a lot of indexes on OCTs which telling us an idea about which hole will close, which hole will have improvement in vision. So there are 3 classifications available for vitreomacular interface abnormalities. Everybody knows this is the GAS classification, this is the International Vitreomacular Traction Society classification, and this is the closed study group classification. I would like to highlight this point once again. The smaller holes we used to do macular hole surgeries, but recently the closed group evaluated larger holes. So they divided holes again into large hole, an extra large hole, double X large hole, and a giant hole. So virtually now we operate on any macular holes. So this is an algorithm for managing vitreomacular interface abnormalities in a nutshell. VMA or just an anomaly you observe. There is vitreomacular traction, the patient is asymptomatic, again you observe but have a close watch. Vitreomacular traction with symptoms, mostly we prefer doing surgery. And macular holes, with or without VMT, with or without ERM, the treatment is surgery. So this is the surgical results of large macular holes, and the study clearly showed that when you use something to stuff the macular hole, definitely the success rate improves. Especially ILMs, macular hydrodissection, human amniotic membrane transplantation, or even an autologous retinal transplantation, all has improved the success rate of large macular hole surgeries. So again, the algorithm for treating a macular hole, oh well, this is a large, look at the size of the macular hole, it's almost 2000 micron. There is a lot of RP damages. Normally we don't take up this case for surgery because the prognosis is not so good. But in the presence of a retinal detachment, we decided to operate this patient because otherwise the patient may land up having a total retinal detachment. And had a successful closure of the macular hole, we did ILM stuffing into the hole. So this is a case of a lamellar hole associated epiretinal proliferation. We did excise this, but not to have much of visual benefit. So the take home message is identify the entity early. Early treatment is the rule. OCT is the investigation of choice, and we have good results if taken up early in the course of the disease. Thank you.
Thank you, sir. Thank you, sir. That was an excellent talk. Now, I next call upon Dr. Prakash. He is the medical director and chief HOD of the Vitreoretinal department at Comtrist Eye Hospital.
Good morning all, and thank you Rahul for this opportunity. So my talk is a treatment algorithm for diabetic macular edema. So as we all know, DME is a major cause of moderate visual impairment, and the sad thing is it happens in the productive age group of the people, and that affects their productivity a lot. The problems we face in managing DME are mainly late presentation, inadequate referrals, lot of comorbidities in this patient, and we all know DME does not respond just like RVO or AMD to anti-VEGF injection. So the poor response is a variable response. Complaints on the part of patients because of the long-term follow-up and multiple visits that are involved, and of course financial reasons. So the treatment starts with, sorry. Okay, so the treatment always starts with a careful ocular examination as well as history taking. We can never, the importance of history taking is cannot be overemphasized, because many times patients have, we have to always look at that drug history is very important. Drugs like glitazone can make macular edema very resistant. Sometimes many of these patients may be on anti-cancerous drugs like MEK inhibitors, which can actually mimic macular edema, also worsen macular edema. Always look at uncontrolled hypertension is many times common because many physicians overlook hypertension. And always look for these subtle signs like disc pallor, thin attenuated vessels, and these discrete hard X rates that you see here. This all can tell you that there is an underlying CKD with anemia going on. These patients may be having recurrent hypertensive episodes also. And this kind of atypical hemorrhages that you don't see, white-centered hemorrhages, flame-shaped hemorrhages that you usually don't see with DME, should always make you think of other blood dyscrasias that are going on, like leukemia. And FFA has to be done, it should be part of the evaluation whenever you suspect an unexplained vision loss due to macular ischemia, or in cases where you have mimickers like this. Macular telangiectasia is a very common mimicker. It can happen in diabetic patients, it can happen along with diabetic retinopathy. So this type of maculopathy, where it might look a non-center involving diabetic macular edema, will look like a center involving maculopathy because of telangiectasia. Also ocular ischemic syndrome also you have to keep in mind. OCT is most important tool, treatment decision making, retreatment, when to stop treatment, all this depends on your OCT finding, and it will also, there are prognostic clues like bridging retinal process or drill changes that will tell you, that will explain, with which you can explain to the patient so that you can increase the compliance of the patient. So coming to proper managed treatment aspects, we will see some clinical scenarios. This can be one scenario where you have a non-center involving macular edema, but there is some hard X rays and thickening outside the center. And in these cases, if the vision is good, you can safely observe these patients with good follow-up. If the vision is affected to some extent, but better than 6/9, and if you feel this is due to the macular edema, and if the macular edema meets the CSME criteria, then you can do a focal laser to the microaneurysms, which are within 500 to 3000 microns from the center of the fovea. So don't do a grid laser, always do a focal laser to these microaneurysms. This is a very common scenario. Actually, one study showed that about 80% of the patients have 6/12 or better vision, even though they have center involving DME. So center involving DME with good vision is a challenging thing, and especially these kind of pictures we see very common where there is a central foveal cyst. So the studies like protocol V has clearly shown that if you either you can do observation or you can do focal laser or inject, the results are the same. So it is always preferable to observe these patients, and if they develop a drop in vision, then you can of course think of starting them on treatment. Or if a patient is symptomatic like metamorphopsia or something is there, then you can think of treating the patient. This is the center involving DME where the vision is already affected. Here always the first line of treatment is anti-VEGF injection. You have two protocols you can follow. Either the DRCR protocol, which is most commonly followed, where we inject monthly continuously till maximum improvement. Less than 10% improvement is achieved. So like if one injection, after one injection, if there is an improvement which is less than 10%, then you consider it as no improvement, and at that point of time you can hold the treatment of the patient, and there is no vision improvement also. Both criteria should be met. No less than 10% improvement and no visual improvement, then you can hold treatment but continue follow-up monthly initially. If there is no recurrence, slowly increase the follow-up period by 2 weeks till maximum of 4 months. So if there is no recurrence, you can continue observation every 4 months. But if there is a recurrence, again you have to switch back to the treatment. And this is another scenario very commonly which we face. We have treated the patient, there was good response, but at one point of time it's not further responding, there is some residual macular edema. Here what you have to do is you have to look whether there is any microaneurysm which is visible clinically, or there is any fresh circinate exudates, or there is a leak on an fluorescent angiography. If any of these present, you can treat them with focal laser and stop treatment. And also stop treatment, don't further treat if there is a subfoveal clump or plaque under the fovea. Then recurrent DME, this is you have treated, patient has responded well, gone back to the end point, but patient recurred after stopping. Here what will you do? Here it is always better to start treating with the same drug which you have injected before, for which it has responded. No need to switch treatment. Then comes non-responders, like this case where after injection actually it has worsened. Non-responder is a very difficult definition because many clinical trials has asked us to wait for 6 injections before we call them as non-responders. But in a real world scenario, we would call them as non-responder after 2 to 3 injections if we are seeing either less than 10% improvement or less than 5 letter gain in vision. Then it is known as a non-responder. Here your option is either you switch to another anti-VEGF. There is no rule that one anti-VEGF it is not working, another won't work. So you can, if you are injecting bevacizumab, you can go to ranibizumab or you can go to aflibercept. Otherwise, you can think of giving steroids also. But the most important thing, if you see a non-responder, is always revisit the systemic status of the patient. See any new drug has been added by the physician. Also, I make it mandatory to get a complete hemogram, CRP, ESR, peripheral blood smear, HB, BP, and in very suspicious cases, get a serum electrophoresis because multiple myeloma, gamma globulinemia, can mimic resistant DMEs. And when do you consider steroids? That is one common situation is responding to anti-VEGF, but patient cannot follow up with you, they are going to gulf or something, then those patients can be converted to steroids. Pseudophakic patients who have reached a plateau with some persistent intraretinal fluid, steroid is an ideal drug before stopping the treatment. Persistent edema patient needs cataract surgery, steroid. And eyes post vitrectomy also, steroid is a good option. And in patients who have systemic thromboembolic events while on anti-VEGF can also be switched to steroids. When do you consider vitrectomy? When you see a vitreomacular interface disorder, like here you can see a thick hyaloid which is developing, which is getting detached, and you see once after injection, still you inject these patients. Don't directly go for surgery, still you can inject, but if there is no response, you see actually it is worsening after the first injection. So those cases you can consider vitrectomy. And with vitrectomy, as you see in the last picture, with vitrectomy it improves, but many times vision may not improve. Macular edema resolves with the vitrectomy. And for DME without any vitreomacular interface disorders, evidence shows that vitrectomy does not help. So you have to continue. Option is only to give injection. With PDR DME is a very common scenario which we face. Always start anti-VEGF injections with in the DRCR net protocol. Just 1 minute. In the DRCR net protocol pattern, and don't forget to stop, to do PRP when you stop injecting, because when you are injecting, the new vessels disappear, even the background retinopathy disappear. This will give you a false sense of security that your DRSS or the diabetic retinopathy severity score has decreased. Your PDR has gone to moderate and PDR you might feel, but don't feel that, because these patients have supraphysiologic worsening of diabetic retinopathy when you stop injection. So they will suddenly progress to rubeosis or PDR. So always don't forget to do PRP once you have reached the end point with injections. And when you have large predominantly vascular NVEs, always start, when the NVEs are very big, then start with PRP, fractionated PRP, small sittings away from the NVE, at least 4 disc diameters away from the NVEs. Then at the end, if macular edema is persisting, then think of injecting. And NVI alone, start with injection and complete with PRP. So this was the case, these are the types of cases. You have clinically these new vessels are not visible, but on angiography you can see large flat new vessels. What happens is, if you inject, then they develop what is known as crunch syndrome, sudden contraction, sudden fibrovascular switch of the new vessels, which will cause the fibrous contractions around the macula and a macular TRD. So don't inject in this case, always do PRP before injecting. And center involving DME in post PRP, this is also very common. Even though 40% of the patients angiographically developed CME after PRP, only 25% require treatment. So in these cases, actually the response to anti-VEGF is poor. Steroids may be a better option. And in cataract surgery, you can always combine, if there is macular edema, combine with an intravitreal steroid or anti-VEGF. And if there is a post-cataract surgery worsening of DME, always think of pseudophakic CME. Also do an angiography, rule out pseudophakic CME. A hot disc and the patholoid pattern will tell you that this is pseudophakic CME, so the treatment is totally different. Otherwise, if it is, you see the microaneurysms leaking, then you think of DME and start the same protocol as you do in a normal DME case. And in pregnancy, anti-VEGF has not proven its safety, so it is always, if the vision is affected and there is a center involving DME, steroids has to be given. And sometimes spontaneously after delivery, macular edema has been shown to improve also. systemic factors, never forget to control, because studies have shown that HbA1c control alone won't resolve the macular edema, but the response to anti-VEGF drugs is much better when the patient's HbA1c improves. So always think of anemia correction, blood BP control, all those issues. So to conclude, real world scenario DME treatment still remains suboptimal for many reasons, as I told, like difficult follow-ups, poor referrals, and some extent complacency from the part of doctors or patients also contribute to this problem. So every attempt should be made to optimize the treatment. We have to minimize the visits and financial loss for the patient. At the same time, we have to try to preserve the vision for these patients. Thank you.
Thank you, sir. Next, I call upon Dr. Rajesh. He is a senior vitreoretinal consultant at Abate Eye Hospital, Pernalmana. He'll be talking to us about algorithm in a case of management of AMD.
Thank you, Rahul, for the opportunity. So, this is one important classification of AMD based on the stages of AMD. So, we know that AMD progresses from early stage to intermediate stage and then to late AMD. And of this intermediate AMD is characterized by the presence of large drusen's. By large drusen's, what is meant is that the drusen's have a size more than 125 microns, which roughly corresponds to the size of a major blood vessel at the disc margin. So patients with intermediate AMD, they are at high risk for progressing to late AMD, which can be either a neovascular AMD or a non-neovascular AMD. So this is a picture of early AMD which progresses to a large the intermediate AMD, and finally it can progress to one of the end effects of intermediate AMD, that can be either a geographic atrophy or a neovascular AMD. So how to follow up a patient with intermediate AMD? So this patient should be followed up ideally at 6 months intervals in the clinic. In the gap between, the patient has to monitor himself at the home with an Amsler chart, preferably with white lines on black background. Patient should be advised lifestyle modification like cessation of smoking, and this is an ideal situation for starting the patients on AREDS2 supplements, because it is known that AREDS2 supplements, they prevent the conversion of early intermediate AMD to late AMD in around 25% of the situations. And whenever the patient visits the clinic, we should do an OCT and fundus autofluorescence. And OCT, mind you, we should always take a raster scans, which will scan the entire length and breadth of the macula. This is to avoid missing an extrafoveal CNVM, which you may miss if you scan only the fovea. Fundus autofluorescence will help us to identify areas of geographic atrophy. And once the patient has progressed into neovascular AMD, when the patient presents to you with the features of neovascular AMD, the first thing is to differentiate it from other entities like PCV and RAP. This is because PCV is a condition which may not respond to our milder or weaker anti-VEGF agents. You may have to treat them with stronger anti-VEGF agents or even PDT. And RAP is another condition which can mimic neovascular AMD. RAP can affect the other eye, and it is also associated with a high incidence of macular atrophy. So it is important to differentiate these entities. Of this PCV, if you look at the OCT, you can fairly, in good number of cases, make a diagnosis of PCV just by looking at the OCT. You can see signs like a tall peak PED. Then we can also see sometimes this round structures under the apex of the PED, which represents the polyps. Then they can also have a double layer sign, which means that the retinal pigment epithelium and the Brooks membrane is separated by the neovascular branching vascular network in between. And important finding is that most of the patients with PCV, they will be having predominantly SRF. They will not be having much of intraretinal fluid that you see in conditions like RAP. And another important finding is that you should look at the choroidal thickness. The choroidal thickness is high in patients with PCV. They may be having a pachychoroid. Now, what do you see in a patient with RAP? RAP patients, this is mainly commonly seen in patients who are elderly, so their choroid is usually thin. Then they will have more of intraretinal fluid than subretinal fluid. So if you see a neovascular lesion with more of intraretinal fluid, you should think about RAP. And when you look at the cross-sectional OCT or the structural OCT, you will see the hyperreflective membrane, which represents the RAP lesion. And if you look at the flow signal under OCT angio, you can see that there is a flow signal corresponding to the RAP lesion. You'll also be seeing an underlying serous PED or fibrovascular PED. And on first OCT angio, you can even pick up the vascular network at the level of the deep vascular complex or in the outer retina. Then neovascular AMD, again the choroid will be thin. You can have two types of neovascular AMD, one under the RP which is on the type 1 and one above the RP which is on the type 2. You can even confirm this presence of the neovascular network with the help of OCT angio, or you can also use a fluorescent angiogram when you are having a doubt. So serous PED with notch, fibrovascular PED, hemorrhagic PED in a patient with thin choroid can also be a representation of neovascular AMD and OCT. So this is a patient who has a hemorrhagic PED with a notch representing type 1 neovascular AMD. So do you do fluorescent angiography in all the patients? Now we do fluorescent angiography very rarely, especially when we are having a doubt regarding the diagnosis. You do a fluorescent angiography. If you see a hyperfluorescent lesion which leaks, then it is more suggestive of a choroidal neovascular membrane. Then another role for fluorescent angiography, I would say, is when you are having an extrafoveal CNVM or extrafoveal macular neovascular membrane, when you are planning treatment, laser treatment, then you should be knowing the size of the lesion before you plan the treatment. Where do you do ICG? ICG is mainly again done to rule out conditions like PCV and RAP. In PCV you will be seeing something called a branching vascular network in the early phases. An important finding is the presence of this hot spot or the hyperfluorescent spot which appears during the first 5 minutes of the ICG. And often what happens is that towards the late phase of the ICG this fades out. On the other hand, in RAP, you can see a hot spot again just like in PCV, but the thing is that this hot spot usually appears towards the mid phase of the ICG and it shows profuse leakage and staining of the retina towards the late phase. Now, how will you treat a patient with neovascular AMD? You should look at the location of the AMD, whether it is extrafoveal, which means that it is located more than 200 microns from the center of the fovea. So for extrafoveal macular neovascular membrane, the treatment is laser photocoagulation. You surround it with laser up to 100 microns from the border of the lesion. When it is a juxtafoveal or subfoveal macular neovascular membrane, the treatment is with anti-VEGF injections. We have a lot of anti-VEGF injections now available. There are various treatment protocols that are available. One is the monthly treatment, which is what is followed in most of the trials. It is the most ideal method of treatment. It gives a perfect visual outcome because the macula is dry most of the time. But then it is something that cannot be followed in our day-to-day practice because it can have much financial impact on the patient, as well as the number of patient visits to the clinic will be more. So we can adopt other protocols like PRN. PRN is where you treat the patient only when the patient has signs of activity on OCT or the patient is symptomatic, having a decrease in vision, or there is appearance of new hemorrhage. The problem with the PRN is that the visual outcomes is not as good as compared to monthly treatment. So another treatment option is a treat and extend. What is important is that every time the patient comes, whether the macula is dry or not, you treat the patient. So initially you try to achieve a dry macula, then try to extend the interval between the visits by 2 weeks up to a maximum of 12 weeks in ranibizumab, and with up to 16 weeks with aflibercept. If at any point there is a recurrence of fluid, you reduce the interval by 2 weeks and continue injections at that interval, and later try extension for one more time. So when will you stop treatment in a patient with CNVM? Once you have completed 2 to 3 cycles of maximum treatment extent, that is 12 weeks for ranibizumab and 16 weeks for aflibercept. And again, you can stop treatment if the treatment is going to not going to be useful for the patient, especially if the patient has got substantial scarring with degenerative cysts and atrophy. And even after discontinuation, always tell the patient to monitor himself for symptoms. And also it is a good idea to see these patients at least 2 to 3 month interval to look for any signs of recurrence. Then there is a subset of patients who have an asymptomatic or non-exudative macular neovascular membrane, which is often picked up with the help of an OCT angio, and there is a sign on structural OCT which says that the patient is having a non-exudative macular neovascular membrane. That is for a shallow irregular retinal epithelial detachment, or SIRE, just like FIPED. In FIPED the choroid is thick, and in SIRE the choroid is thin. That is the main difference. You will see this neovascular membrane there. This neovascular membrane is not treated unless the patient develops symptoms or there is appearance of hemorrhage or fluid. Now this is another situation. You see a patient with a neovascular membrane with subretinal hemorrhage. If the hemorrhage is small, you can try anti-VEGF injection with gas for displacement of the hemorrhage. But if the patient is having a thick hemorrhage, then sometimes you may even have to go for a vitrectomy with a subretinal or intravitreal TPA and subretinal or intravitreal anti-VEGF along with gas for the displacement of the hemorrhage. There are certain set of patients who do not respond to anti-VEGF injections right from the beginning. They are called a non-responder or the primary treatment failure. In such situations, you may try changing to a different anti-VEGF agent. You should also try to find out whether the diagnosis is correct, whether you're dealing with some other situation, and if still it points towards a diagnosis of neovascular AMD, try switching to a different anti-VEGF agent. But there is another subset of patients who responds initially to the anti-VEGF, then they stop responding. It could be due to tachyphylaxis or improper dosing of the medication. Then again, another option is to switch to a different anti-VEGF agent, or you can go back and see whether your treatment protocol is right. If it is the gap between the injections is too high, then you can try to reduce it to monthly injection and see whether it works. In patients with cataract, always try to achieve remission of the lesion before you go for cataract surgery. And even after cataract surgery, always make sure that there is no recurrence of the lesion. And if there is a recurrence, then you treat the patient. The non-neovascular AMD, this is one situation where we never used to have any treatment till now, but now there are certain treatment options are available. Before that, we just used to follow up this patient with OCT, mainly to rule out the presence of an associated neovascular AMD, which can happen in patients with non-neovascular AMD. It also helps assess the progression of the disease. Then we also used to take fundus autofluorescence to assess the extent of atrophy and monitor progression. But now there are treatment options available in the form of complement inhibitors and complement because complement pathway or the inflammation secondary to the complement activation is supposed to be having a role in the development of geographic atrophy. So there is something called a C3 inhibitor and a C5 inhibitor that is available. C3 inhibitor is called Syfovre.
I would like to comment on fixing the globe by putting a groove on the left-hand side for the right surgeon, right-handed surgeon, putting a
it's from the other hole.
partial thickness groove on the left hand of the
Okay, so
canal.
C5 inhibitor or C3 inhibitor. C5 inhibitor is known as
What are the
ACP
limbus?
or Isovay, and the C5 inhibitor, because it is being way down in the complement pathway, it is supposed to have a better result compared to C3. So in future, for patients with geographic atrophy, we will be injecting these patients. They have shown very promising results with monthly and bi-monthly injections of C3 inhibitor and C5 inhibitor. Only problem is that these injections are now associated with a high risk for development of choroidal neovascular membrane.
Partially. No. Clearer.
And it has also been proved that when we inject this patient with C3 inhibitor, it actually delays the progression of macular atrophy from a stage called iRORA to C-RORA. This is just a OCT-based classification of macular atrophy that we see in non-vascular AMD. C-RORA is where you see a loss of RP band or attenuation of RP band in an area which is having a diameter of 250 micrometers or more. And it can also have hypertransmission of the choroid, which as a result of the RP band attenuation. We can also have features of photoreceptor degeneration. Again, all these lesions are having an area, having a diameter of 250 micrometers or more. When these findings are in an area which is less than 250 micrometers, they call it iRORA. Now it has been shown that with the C3 or C5 inhibitors, we can actually reduce the progression or reduce the rate of progression of iRORA to C-RORA. Thank you.
Thank you, sir. Next, I call upon Dr. Risha. She is a senior consultant in the Department of Uvea at LF Hospital, Angamali.
Thank you, Rahul. I'll show you algorithm for a case of posterior uveitis. Here, there are some examples of posterior uveitis. All look very much similar, but they have different etiologies. Some are infectious, some are non-infectious. Here comes the role of correct protocol so that we can prevent the permanent vision loss. And this is the protocol for the management of posterior uveitis. First, describe the uveitis, then mesh it, comparing the existing diagnosis, and general and specific lab testing to evaluate the patient. Then specialist consultation to confirm the systemic disease and start treatment. Then start treatment, then follow up. How to describe the uveitis? in terms of age, chronicity, anatomic location, laterality, severity, depending upon the pathology, pattern of uveitis, and depends on the etiology. After reaching the etiologic diagnosis, treatment depends upon the anatomic location, whether it is anterior, intermediate or posterior, whether it is only ocular disease or if it is associated with any systemic illness, and whether it is infectious or non-infectious. I'll give you some examples. This patient presented with a young male presented with the vitreous clouding. So that was a case of posterior uveitis. A systemic evaluation was within normal limits. Uveitis specific history and investigations all were normal. But he gave history of IV drug abuse, so we suspected infectious etiology. ACTAP PCR was sent, came to be positive for fungal genome. He had undergone vitrectomy with intravitreal antibiotics. So the whole treatment is over. Next, see this lesion, it's very clear that the lesion is far behind. It's a choroidal lesion. OCT confirms the anatomic location of the lesion. And here the patient was young and pregnant also, 7 months. She had a history of contact, TB contact, her mother and sister. So Manto was done, was positive with raised ESR. She was treated only with ATT, and this was the picture after 2 months of ATT. And see, this is yet another type of lesion. Here it is retinitis, not like choroiditis as in the previous case. Whenever you see retinitis lesions, always rule out viral etiology. This patient was on immunosuppression for vaginous granulomatosis, and CTAP PCR came to be positive for CMV virus. So she was treated with the intravitreal ganciclovir, and physician reduced the dose of immunosuppression. Yet another lesion. This is not a full thickness retinitis, but it's not a choroiditis lesion also. OCT shows deep retinal involvement. FFA shows disc edema and vasculitis. Patient was evaluated for all the causes of retinitis, especially atypical cases. VDRL and TPHA came to be positive. Patient was referred to dermatologist for crystalline penicillin along with steroids, and lesion completely resolved. This patient was referred as post-fever retinitis, but on meticulous examination was found to have high BP. A 23-year-old male, high BP with raised renal function. So that was a case of hypertensive retinopathy. Again, another patient with a hypopyon uveitis with vitritis and vasculitis with painful aphthous ulcer, referred to rheumatologist for treatment of Behçet. This patient only ocular illness with bilateral panuveitis, pinpoint leaks with late pooling, and skin and hair changes. No need to refer to anywhere. You only treat with the steroids and immunosuppressants. Another patient with bilateral occlusive disease, occlusive vasculitis with malar rash. Again, send the patient to rheumatologist for SLE evaluation and treatment. Another patient with granulomatous uveitis, candle wax dripping and snowballs with skin lesions. Refer to pulmonologist or rheumatologist for evaluation of sarcoidosis and further treatment, and monitor the ocular condition. Always these ocular signs will give you some clue regarding the diagnosis. Whenever you see granulomatous KPs, rule out TB sarcoidosis, and pigmented KPs, rule out viral etiology, and this type of crenulated KPs, stellate KPs, Fuchs should be kept in mind. And another patient with panuveitis in one eye and other eye history of trauma or surgery, rule out sympathetic ophthalmia. Again, no need to refer anywhere. Start steroids and immunosuppressants. This patient was treated as intermediate uveitis initially with systemic steroids, but on careful indirect ophthalmoscopy revealed an active toxo lesion in the mid-periphery. So start antibiotics with steroids in these cases. And try to identify different patterns so that you can come to the diagnosis easily, like all this. And think about non-uveitic conditions also. This patient had chronic uveitis, but all symptoms started only after cataract surgery, and on careful examination you can see these plaques behind the IOL. So that was a case of P. acne and off. And do not miss subtle changes of reactivation. In these cases, investigations, especially autofluorescence, helps in detecting this early reactivation in these cases. And here comes the role of imaging. This is a case of juxtapapillary toxo lesion. OCT shows the retinitis lesion, but CFFA shows an associated BRA also. So to summarize, whenever you see signs of uveitis, complete history and review symptoms is a must. Then detailed ocular examination with systemic evaluation, then classify according to the anatomic location and list the differential diagnosis and do stepwise diagnostic workup. And whenever you have a doubt or you are not getting enough outcome, then go back to the history again and do everything again. Thank you.
Thank you, ma'am. So I think we are running short of time, so we have a couple of minutes. Any question from the audience? So, okay, I'll just try to put in a few questions from the audience perspective. So, Dr. Shane, a patient comes to you with defective vision. Okay, he has a cataract and as well as an ERM. When would you advise a cataract surgery alone or a combined procedure?
So a careful evaluation of the symptom is extremely important. But in case of dense cataract, obviously the majority of the symptom would be a defective vision. But many a times you might see that there is a subtle cataract and the patient may have other symptoms like metamorphopsia. Or he might say that he had mild curving of letters, but now it is more of a deterioration in vision. So by the symptom itself, we know whether is it cataract and ERM which is causing the problem together, or is it cataract alone or ERM alone. But having said that, there are certain OCT parameters now I rely upon mostly to decide whether to do combined surgery or not. If I see that the ERM is altering the foveal contour, if I see that if there is an ectopic inner foveal layer, I would definitely know that this patient could be symptomatic after a cataract surgery, and then I would be probably discussing the patient to do a combined procedure. Combined procedure also has got the advantage that with one procedure the entire disease entities are taken care of. Those days when the complications of vitrectomy was very high, probably it was prudent enough to say that go ahead with cataract surgery alone and then we'll do another surgery later on. But the success rate is near about cataract. I recently evaluated my 5-year data on ERM with cataract surgeries, and my rate of complication, I'm not boasting about it, it's a fact, it's going to get published soon. It was 98% success rate. And the complication we had was an ectopic macular hole which developed in one of the cases. But none of the other cases had any deleterious effect on doing a vitrectomy along with the cataract surgery, even for early epiretinal membranes.
Thank you, sir.